Good morning. I'm Jerry Ellstein. I'm going to talk to you about rheumatoid arthritis of the hand and wrist. This is a condition secondary to synovial hypertrophy and inflammation. You get blood vessel proliferation in the synovium and chronic erosive synovitis. This occurs in about 1% of the population, and women are greatly affected more so than men. It is a systemic autoimmune disorder. Deformities increase with age, and it can affect any joint, but small joints of the hand and feet are most commonly involved. The wrist is involved commonly up to about 50% of cases within 2 years of onset of the disease, but increases to over 90% at 10 years. The diagnostic criteria by the American Rheumatologic Association includes morning stiffness, swelling, nodules, positive lab findings, and X-ray findings. The manifestations of the disease can lead to deformities involving tendons with tenosynovitis and tendon ruptures, and joint involvement with synovitis, instability, and articular surface destruction. Common hand deformities include swan neck and boot and ear deformities of the digits and thumb, which I'll discuss later, joint subluxations, joint dislocations, ulnar drift of the fingers, radial deviation of the hand, volar subluxation and supination of the hand and wrist with apparent distal ulnar dorsal subluxation, digital flexion contractures, ankylosed joints, unstable or floppy joints, and also joints. Tendon involvement will include the Vaughan-Jackson syndrome, which I'll discuss, in addition to the Capponi syndrome. Rupture of the extensor pollicis longus is common, and ruptured wrist extensors associated with volar wrist subluxation and dislocation. Subluxation in particular, or dislocation of the extensor carpiulnaris, will contribute to that deformity as well. Extensor tenosynovitis occurs, can occur both in digits, palm, and in the wrist. A generalized flexor tenosynovitis can occur. And then there is the Manifeld syndrome with digital flexor tendon ruptures. You also can have involvement of with carpal tunnel syndrome, posterior interosseous nerve syndrome, and cubital tunnel syndrome. Clinical manifestations include the characteristic ulnar deviation of the digits. The ulnar side of the wrist is the affected first with volar subluxation of the carpus. It's a relative supination. The extensor carpiulnaris becomes ineffective for wrist extension as it rotates volarly to the center of rotation. A Z deformity of the hand and wrist occurs due to rotatory subluxation of the scaphoid from wrist synovitis. Wrist extension leads to radial deviation of the metacarpals, and ulnar drift of the phalanges occurs. Non-operative management includes medical management with non-steroid anti-inflammatory medicines and DMARCs. This has resulted certainly in a decreased number of patients needing hand surgery, but it does not completely eradicate the need for surgery. There are patients that are not treated or are resistant to medical management. Rest, controlled exercises, splinting can be used, although the splints will not correct deformities. Steroid injections can be used cautiously in education patients is what's key. So surgical indications include prevention of deformities, pain relief, restoration and improvement of function, and improvement of appearance, important for the patient. With regard to staging of procedures, it is recommended to address the proximal problems first, the shoulder, elbow, and wrist. Rehab should not be impeded by more proximal pathology. The upper extremity can take precedence over the lower extremity, and sometimes address the lesser involved hand. Maximize function quickly, and combine hand and wrist procedures where possible. In preoperative consideration, evaluate the patient's cervical spine. Do they have any instability? And this may require some flexion extension films if general anesthesia is considered. Cessation of medications, NSAIDs, 7 to 10 days pre-op. Methotrexate, in the classic sense, is discontinued 2 weeks pre and post-op, secondary to a higher risk of infection. But some of the newer literature is supporting continuing the medication to help patients decrease inflammation. And it may require some steroid doses as well. Sauter described a grading of surgical procedures for rheumatoid arthritis, with the top group being the most reliable and the last group being the least reliable for benefiting the patient. And in group 1, you have fusion of the MP joint, extensor tenosynovectomy, and Darrow procedures. Groups 2 are synovectomy, MP arthroplasty. Third group, PIP fusion and wrist stabilization, and then the swan neck and finger correction and correction of boutonniere deformities as being less reliable. With regard to examination of the patient for tenosynovitis, look at this photo, and here you can see a positive tuck sign. The extensor tenosynovium gets tucked underneath the skin as the fingers flex and extend, and it helps you distinguish this from, let's say, a ganglion cyst. With regard to flexor tenosynovitis, many of these patients have a decreased active range of motion, but their passive range of motion is greater. The tendons just don't slide well. The management of tenosynovitis initially is conservative with medication and splinting, but the indications for tenosynovectomy are persistent tenosynovitis over 4 to 6 months, or a rapid increase in the area of the tenosynovitis, recurrent disease, and of course late presentation of tendon ruptures. The cause of tendon ruptures can be either a synovial infiltration with attrition of the tendons. If the tendons rupture in the hand or digit, it is most commonly caused by synovial infiltration. Tendon injury also can be due to ischemia from external pressure, prominence from the ulnar head, the Caput-Olney syndrome, and leading to extensor tendon ruptures, the Vaughan-Jackson syndrome. Tendon injuries also can occur from bony spicules, most commonly within the carpal tunnel, and this is the Mannerfeld syndrome, with rupture of the flexor pollicis longus and the flexor digitorum profundus to the index finger. Extensor tendon ruptures are quite common, with the ulnar portion of the hand more frequent. The EDC and the EDQ rupture most commonly in rheumatoid arthritis. The distal radial ulnar joint instability due to attrition of stabilizing structures become problematic, leading to volar subluxation of wrist and hand on the radius, and it leads to prominence of the ulnar head. You get ischemic necrosis of tendons in combination with synovial infiltration, leading to rupture and extensor tendon rupture of Vaughan-Jackson syndrome. Extensor tendon ruptures can be painless, the onset may be sudden, and the progression is usually radialwards, starting with the small finger extensors. The management of extensor tendon ruptures includes end-to-end repairs, which are very unlikely. These tendons are not in good condition. Adjacent tendon suture, common. Take the extensor digitorum communis to one finger and transfer it over side to side to the adjacent intact extensor tendon. Tendon grafts can be carried out, but it's more difficult in a synovitic bed to get these to slide. Tendon transfers, you need to follow the tenets of tendon transfers with joint being able to flex and extend as well. And when you operate and do extensor tenosynovectomy, you can transpose the extensor retinaculum deep to the tendons for protection as well as superficial to it to prevent bowstringing the tendons with wrist range of motion. Tensioning the tendons can be carried out with good finger extension with 30 degrees of wrist flexion and good finger flexion with 30 degrees of wrist extension. You could consider doing this under a Wallant type of anesthesia if possible, but these are extensive procedures to be carried out. Tendon transfers, for example, the EIP can be used as well as the flexor digitorum superficialis of Ring and Long if the extensor digitorum communis tendons are ruptured. I frequently will remove the distal ulnar with ECU stabilization or Swabi-Kapandji procedure at the same time. And here's an example of treatment of extensor tendon rupture to the small finger with a transfer to the side of the ring finger, including excision of the distal ulna. Now, how do you know extensor tendon is ruptured? Well, there are a few things that you need to compare and see if that is truly the problem. So is there any subluxation of the extensor digitorum communis at the metacarpal phalangeal joint due to sagittal band disruption? Or can the patient maintain finger extension if the finger joint is passively extended, recentralizing the extensor tendon? The other condition to look for is posterior interosseous nerve compression at the elbow due to synovial proliferation. And you'll see the tenodesis effect in place if it's the PIN is not functioning. But if it's a extensor tendon rupture, you lose the tenodesis effect. For flexor tendon ruptures, the FPL is the most common to rupture in the carpal tunnel, the Mannerfeld syndrome. And again, it's typically due to a spur on the distal pole of the scaphoid. The treatment can be either IP joint fusion or tendon transfer as listed here. Now, there are different ways to treat rupture. The postoperative management includes splinting, extension splinting for extensors, splinting and some flexion for flexors, thumb spica for the flexor pollicis longus, immobilization, and then some early range of motion controlled with hand therapy. And being cautious with these tendons for about 12 weeks. Well, what are the outcomes? In some prior studies, there were good outcomes with extensor pollicis longus tendon transfers for rupture and extensor digiti minimi transfers for rupture. But the results decreases as more tendons are ruptured. With regard to flexor tendons, 88% of flexor tendon transfers regain motion, but the motion is not very good. Tendon ruptures due to attrition do better than tendon ruptures due to synovitis. We're going to review now some joint synovitis management, and that any joint can be affected, the DRUJ, the radial carpal, or the finger joints. Initial treatment is conservative with medications, injections, and splinting. The indications for synovectomy are persistence of symptoms for 6 to 8 months, a reasonable joint surface remaining, and problems with weighting, progression of cartilage destruction, and soft tissue disruption. DRUJ synovectomy can be reserved just for early cases, and this allows for treatment of tenosynovitis at the same time and treatment of ruptures as well. For radial carpal synovectomy, there are two methods: the open procedure, which allows for treatment of the DRUJ at the same time, as well as allows for treatment of the extensor tendon for tenosynovectomy. Arthroscopy has a place, perhaps a faster recovery, less soft tissue handling, but the long-term effects are still unclear. However, it can be used in select cases. I just did one last week, and also if a diagnosis is questioned when a tissue sample is requested. For MP joint synovectomy, you can develop synovitis with progressive ulnar deviation of the digits. These joints may be preserved with good cartilage, but may be subluxed. This condition occurs due to attritional lengthening of the radial sagittal band and the radial collateral ligament. And in cases with severe synovitis refractory to conservative management, but without significant cartilage degeneration, you can perform MP joint synovectomy without arthroplasty or joint replacement. You can centralize the extensor tendons by imbrication of the radial sagittal band, reconstruct or imbricate the radial collateral ligament, and also perform cross-intrinsic transfers. Here's an example of imbrication of the radial sagittal band to the centralized EDC tendon. For joint arthritis, again, all joints can be affected. The initial treatment is conservative, medication, injections, splinting, and indications for reconstruction would be persistence of symptoms in spite of conservative management, pain, and functional disability. With regard to the distal radial ulnar joint, the indications would be articular cartilage destruction. The Dara procedure remains the gold standard here. It is a transverse distal ulnar resection with or without ECU stabilization. I typically do this with a distally based ECU stabilization technique and capsular imbrication. Other procedures done at the distal radial ulnar joint, including hemiresection and wafer excision, can be used occasionally, but you need an intact TFCC in order to perform that. They're less commonly used. The Swaby-Kapanji procedure is a distal radial ulnar joint fusion with pseudoarthrosis created proximally to it to allow rotation. Sometimes this can also be stabilized further with a ECU distally based transfer. And finally, there is distal radial ulnar joint arthroplasty. When to do the Dara procedure? Perhaps the older sedentary patient a stable radiocarpal joint, so there isn't ulnar translocation. Take away the end of the ulna and carpus can continue to translocate with the lunate dislocating. So contraindications would be pre-existing carpal instability with ulnar translocation and excessive radial tilt or palmar instability. The results are good with proper patient selection. Again, stabilized with a portion of the ECU distally based. The complications from it can include ulnar stump instability with dynamic convergence causing pain and extensor tendon rupture. Here's an example of a distal ulnar resection. This patient also has had other procedures done at the carpus. The indications for a Swabic-Kapandji procedure may be a younger patient. It allows for increasing the radiolunate fusion mass. The contraindications would again be pre-existent radiocarpal instability. Complications from this can occur, including clunk with rotation, the possibility of non-union of the distal ulna to the radius, and premature healing of the pseudoarthrosis causing loss of forearm rotation. The Bowers hemiresection with interposition and the Watson match resection are procedures still carried out, but predominantly for the non-rheumatoid patient. Again, you would need an intact TFCC for this, and there's not a lot of data on these procedures for patients with rheumatoid arthritis. The contraindications would be disruption of the TFCC, and relative contraindication is an ulnar positive variance, which can result in possible continued future ulnar carpal impingement. You can shorten the ulnar styloid and the ulnar, but again, not commonly done. How about arthroplasty? Indications include when joint surfaces are lost without significant bone loss. If there is bone loss of the sigmoid notch, you can reconstruct this by osteotomizing the radius to align the DRUJ. It's also available are hemiarthroplasties, metallic implants, and then an aptus, more constrained type implant. The results are typically good to excellent. However, we still need to study long-term results. For wrist arthritis, treatment can be either partial arthrodesis, total wrist arthrodesis, or arthroplasty. The characteristic findings of the wrist arthritis are radial deviation of the radiocarpal joint, radial deviation leading to ulnar drift of the digits, and in cases with attritional deficient structures on the ulnar side, they can develop ulnar translocation of the carpus, with 50% or more of the lunate hanging off of the radius itself, lunate facet. The management of radiocarpal arthritis can be partial arthrodesis with a radiolunate and a radioscaphoid fusion, and indications for this would be patients who wish to maintain some range of motion, but they have to have a reasonable midcarpal joint. There also shouldn't be significant ulnar translocation. The contraindications would be significant midcarpal arthritis and rapid progressive disease. Here's an example of partial wrist fusion. There is some joint in the midcarpal joint here, but certainly not normal. Total wrist arthrodesis offers the best options for patients with rheumatoid arthritis. If both wrists are affected, suggestions can be to do an arthrodesis on one side and perform an arthroplasty on the other. The indications would be arthritis, which is pancarpal and erosive. Contraindications would be inability to tolerate motion loss due to other major joint involvement that cannot place the hand in space sufficiently, such as elbow and shoulder arthritis. And also infection would be a contraindication. There are various techniques for wrist arthrodesis. There's a sliding bone graft from the distal radius, or you can use iliac bone graft. Steinman pin fixation, which is intramedullary placement of Steinman pins, often done in association with MP arthroplasties. And it can be appropriate for those patients with severe osteopenia and poor bone stock where you don't want to use plates and screws. And the other choice is plates and screws. With regard to the Steinman pin fixation techniques, Nalibuff described intramedullary placement through the metacarpals into the carpus and through into the radial intramedullary canal. This was modified by Feldman to start between the metacarpals, and this is another good technique as well, especially if you're not doing MP arthroplasties. It's a good technique for poor bone stock. You can use as many pins as necessary, and the pin should occupy at least 50% of the length of the metacarpal. Compression plating is useful for patients with adequate bone stock. It allows for early mobilization and these pre-contoured plates make the procedure more straightforward. So there are similarities with all of these procedures. You need meticulous soft tissue handling. The skin on the dorsal aspect of the hand is thin and delicate. You need to transpose the extensor pollicis longus, denude bony surfaces to be arthrodesed, evaluate any joints considered arthritic on the X-ray to possibly incorporate to the fusion mass, evaluate the distal radioulnar joint, and it is common to perform a Darrow procedure at the same time. Fusion can be about 20 degrees of extension, one side neutral if bilateral to allow for perineal care. The results of wrist arthrodesis are generally good to excellent. The outcomes are largely dependent upon achieving bony fusion. Complications could be either pin migration or plate and screw soft tissue irritation or loosening. How about arthroplasty? It's still enticing, but there's no conclusive evidence to support the use of the prosthesis over an arthrodesis, and the long-term outcomes are still not known well for rheumatoid arthritis. One study showed that patients with bilateral procedures and arthrodesis on one side and arthroplasty on the other tended to use the side with a prosthetic replacement for ADL. Perhaps it's good for a lower demand patient, but the concerns are loosening, especially in rheumatoid bone. We're going to move on to MP joint arthritis. And you must address the more proximal joints before moving to the MP joints. You need to have a balanced wrist, otherwise you're going to get ulnar drift again. And arthroplasty is indicated when the joint destruction has occurred. These joints are significantly subluxed or dislocated. When there is significant ulnar drift, volar dislocation, and pain. The contraindications would be poor bone stock or poor soft tissues. In patients who are pain-free, who have good function in their hand, an arthroplasty will not increase the patient's function and indeed may weaken their grip strength. My choice is still to use a silicone implant arthroplasty. There are other prostheses available as well. I like to add grommets to these, and I've had a good long track record with patients doing this. The dorsal approach is used. You can use a transverse incision as seen here, or you can go intermetacarpal as well, making 2 incisions. You can divide either the radioulnar sagittal bands, imbricate them, and centralize once the arthroplasty is carried out for these patients. I combine this with reconstruction of the radial collateral ligament as well as cross-intrinsic transfers. Well, what's the outcomes? All fingers showed an improvement in ulnar drift from baseline to 1 year after surgery. The smallest improvement was in the index finger, and the largest improvement was in the little finger. Similarly, the largest improvement in extension lag was seen in the little finger, and the smallest improvement was seen in the index finger. In terms of the MP joint arc of motion, all fingers moved to a more extended posture and gained an improved arc of motion, but the biggest improvement was observed in the 2 ulnar fingers and less in the 2 radial fingers. We're going to move on to some finger deformities and discuss rheumatoid swan neck deformities. What is it? Well, Landsmeer described a swan neck deformity as a terminal imbalance of an intercalated segment in a bimuscular, biarticular system. What is that? It's hyperextension deformity of the PIP joint with a concomitant extensor lag at the DIP joint, often associated with some degree of MP joint flexion. We're going to talk about 4 types of swan neck deformities. The first is flexible in all positions, and these patients are often treated with a flexor tenosynovectomy. Type 2 is limited with MP joint extension. In other words, there's intrinsic tightness, a flexor tenosynovectomy, some intrinsic releases. Tenodesis or dermodesis can be added. Type 3 there's limited motion in all positions of the MP joint, and these patients have articular and paraarticular problems. You can try doing manipulations, lateral band mobilization, capsulectomy, and extensor lengthening, as well as palmar arthroplasty and fusion. These are difficult to treat, and the soft tissue procedures are less reliable and durable. Finally, with PIP joints that are stiff with advanced arthritic changes, arthroplasty or fusion are indicated. Moving along to the rheumatoid boutonniere deformity, there are 3 classifications, 3 types. 1 is mild with an extensor lag of only 10 to 15 degrees and some DIP joint hyperextension. The treatment is extensor tenotomy over the middle phalanx. In a moderate boutonniere with more 30 to 40 degrees of lag, there's intrinsic tightness, and the DIP joint is hyperextended. Central slip shortening, mobilization of the lateral bands, and tenotomy can be carried out in the severe stage with fixed flexion posture and the DIP joint hyperextended. Although you can try release of contractures and splinting, arthroplasty or fusion is much more reliable. Finally, in rheumatoid thumb deformities, there are 5 types. The boutonniere is the most common. The swan necks are also common, and I typically see gamekeepers where you get a combination of deformities, and combination of types 1 and 3 together are rare. Finally, instability of the IP or MP joint due to joint destruction can be seen, such as in arthritis mutalis. So in summary, non-operative treatment of rheumatoid arthritis includes the use of anti-inflammatory meds, splints, and therapeutic modalities. Surgical treatment includes synovectomy, arthrodesis, and prosthetic replacement. This disease is not fully eradicated, even with availability of modern drugs. Let's go over a few questions. A 67-year-old woman with painful rheumatoid arthritis presents for metacarpophalangeal joint arthroplasties of all 4 fingers. What is the expected functional outcome 1 year after surgery? And the answer is decreased extensor leg and improvement of the ulnar drift. A 45-year-old man with a history of rheumatoid arthritis reports he is unable to extend his ring finger. Exam reveals that with active extension, he has a 60-degree extensor lag at the MP joint. But when the finger is passively extended, he can maintain it in a fully extended position. Treatment should consist of sagittal band reconstruction. Which of the following changes typically occur in inflamed synovium in patients with rheumatoid arthritis? And the answer is blood vessel proliferation. And finally, a 51-year-old woman with a rheumatoid arthritis suddenly unable to actively extend her ring finger and little fingers on her dominant hand. What is the most likely diagnosis? Attritional rupture of extensor tendons at the wrist. I have one more, but this is also patient is unable to extend her middle finger. Not only does her finger stay flexed, but it gets ulnarly deviated. The exam shows her finger flexed at 60 degrees. The finger can be passively extended, and then she can maintain it again. And you should know the answer to this one is extensor hood reconstruction. Thank you. I know it's been a whirlwind tour, but I wanted to review as much of this as possible with you in the time allotted. Thank you.